From anatomy to anesthesiology, from pathology to pharmacology, from microbiology to medicine, a one-man resource to the world of health sciences. Welcome to Dr. Paul's Medical Lectures. A practicing physician, Dr. Paul offers you essential insights on diseases afflicting millions of people around the world. For today's lecture, here is Dr. Paul.
For tuning to our channel today. This evening I want to talk a few minutes about atopic dermatitis, that is eczema. There are certain characteristic features when we talk about it. It is pruritic. It will have lichenified eruption on the face, neck, upper trunk, wrist and hands, in the antecubital and popliteal folds. So you see, atopic dermatitis is a very, very important disease. It appears in different forms at different ages, but there are certain diagnostic criteria for eczema. They include, it's a very pruritic, it has a typical morphology and distribution like a flagellar lichenification, sometimes or hands and nipple eczema or eyelid eczema. Then it starts its onset in the childhood. Then its chronicity, it's a long-term disease. And you will also see a family history of atopic dermatitis. Many patients complain of asthma, allergic rhinitis, atopic dermatitis as a unit. Then sometimes patients develop that infraorbital thickening of the skin just under their eyes. Then you will also see increased serum IgE levels. So these are the characteristic features of atopic dermatitis or eczema. And many times patients develop that lichenification. And most importantly, you should always differentiate eczema from seborrheic dermatitis. You see, seborrheic dermatitis is not that pruritic. But atopic dermatitis is a very, very pruritic condition, and it causes almost a pigment loss in dark-skinned people. So in black patients in United States, for example, the pigmentation may be lost in lichenified areas. So when you see these flare-ups of this disease, you should always think about this lichenification. Now, laboratory findings, most importantly, eczema is diagnosed by clinical features, but many times you can see about food allergies, other food allergies in these patients. And radioallergosorbent rash test or skin test may suggest some dust mite allergy, and you can see high elevated IgE levels in the serum. But mostly this disease is diagnosed by clinical features. And as I said, eczema must be distinguished from seborrheic dermatitis. Seborrheic dermatitis is less intense. It mostly involves the face or the scalp, and it comes with scaly lesions. Also, seborrheic dermatitis responds quickly to therapy, unlike eczema that takes a prolonged response to treatment. So folks, remember these points because they have high clinical value in your practice. You will certainly see patients with eczema, and you should know well how you are going to identify this disease, how you are going to differentiate it from other diseases. Now, treatment. First of all, patient education is very, very important because this is a chronic condition. And many patients become impatient because they don't see immediate response. And you need to educate them very, very well. And atopic patients, they have this hyper-irritable skin. That's why anything that irritates their skin should be removed from their atmosphere. And atopic individuals are sensitive to low humidity and often get worse in the winter. So they need special precautions to follow in winter. And they should not bathe more than once daily. and soap should be confined to the armpits, groin, and scalp and feet, and wash clothes and brushes should not be used. And after they rinse, they should pat the skin like this, pat it, and then apply a thin film of emollient. Any emollient like Aquaphor or Eucerin cream or petrolatum or any of this. You need to use like a small film over the skin. Then local treatment, corticosteroids should be applied sparingly. So you take a steroid cream and you apply it once or twice daily after you apply the emollient. And you can start with a mild like triamcinolone. So take a mild steroid and apply it as needed. And if it does not respond, and if it is getting worse, then you can go to higher steroids, high potency steroids. But always start with low potency steroid and use only as needed, because you see corticosteroids, they come with their own side effects. The other agents are tacrolimus, that is protopic, and pimecrolimus, that is Elidel. So protopic and Elidel, they are effective when applied twice daily. But the problem, folks, both protopic and Elidel, they got these black box warnings from FDA, because both tacrolimus and pimecrolimus, there are concerns about the development of T-cell lymphoma. So T-cell lymphoma can happen, and that's why you should use these agents sparingly. Subacute or scaly lesions. Whenever you see a scaly lesions in these patients, you have to go higher up in the steroid potency. Go for mid potency or high potency steroids and apply them as a thin film over the skin. And chronic dry lichenified lesions, whenever these patients develop them, that means the skin, the disease is getting worse and it is becoming more and more resistant to the treatment, and then you have to go for ultra high potency corticosteroid ointments. And is there any systemic or adjuvant therapy? Yes, sometimes you have to go for systemic corticosteroids, but that's only limited to severely acute exacerbations. You have to give oral steroids sometimes. And what about pruritus? Go for antihistamines like diphenhydramine, hydroxyzine, or doxepin to treat this itching. And whenever you see the fissures and crusts and erosions, then the patient can get staphylococcal skin infections. When that happens, you should use anti-staphylococcal antibiotics, and sometimes first generation cephalosporin may be helpful in management. So you need to take the cultures and see what exact bacteria are growing on these lesions and go accordingly. And smallpox vaccination is absolutely contraindicated in patients with atopic dermatitis. All right, remember that, because these patients, they develop eczema vaccinatum. Okay, so do not give smallpox vaccine in patients with atopic dermatitis. That's a very, very important point, folks. So I hope you got something out of this, and please post if you have any important points on this very important skin disorder. Thank you very much.
Thanks for listening. For more medical videos, please visit us at www.drpaul.org and take time to browse through hundreds of health videos we regularly post on our site. If you are preparing for USMLE, PLAB, and other medical exams, make sure you visit our website to browse through our videos explaining the essential points you need to know before taking these examinations. For more information, visit us at www.drpaul.org. Thank you, and may God richly bless bless you. Are you preparing for USMLE? Please do not waste thousands of dollars on training courses. Get the books written by Dr. Paul with the student-to-student tips and memory aids. The success will be yours, and you will soon realize your dream of becoming a physician in the United States. If you are preparing for Step 2 clinical skills, study USMLE Smasher, a guide helping thousands of medical students to pass this examination. For more information, visit us at www.drpaul.org.